Good afternoon, everyone. I would really like to thank the Scientific Committee of AIOS for giving me this opportunity. And without wasting too much time, we'll quickly jump into the topic, which is imaging in the ocular surface. This is a session more like a debate where we'll be primarily focusing on the dry eye diagnostics to know whether it's a necessity or monetary, as the other aspects of ocular surface imaging are being covered in the subsequent talks. So, uh, so I do not have any financial disclosures to make, though we have most of the machines being discussed in this talk. There's no financial disclosures. So all of us really know that dry eye disease is very complex. It has multifactorial etiopathogenesis, and all these factors are actually intertwined and very intricately connected. So it's very difficult to both diagnose and also manage patients with dry eye disease, which often is the biggest difficulty we face. So firstly, we need to actually understand the impact of dry eye disease. It's not like before where only the elderly or the very severe forms are the ones who need treatment. But in a large hospital-based study, we could really know that it's affecting all the age groups, much younger in the younger age amongst men and older age amongst women. And it's also alarming to see that there was significant visual impairment even amongst children. So this is even more relevant in the current times with the COVID pandemic, where video display unit use and evaporative dry eye are only going to spike up even more. But the challenge we continue to face is that there is no single diagnostic test or a machine that can actually establish the diagnosis of dry eye, which is also a reason there are so many of these machines in the market, and we don't know which ones to actually use or which ones to pick. So this is the reason why objective assessment of dry eye disease has come into vogue, because it helps us capture the images. We can capture them in real time, record them, and analyze them. This is generally accepted in research, and sometimes it's can easily pick up a very early or subclinical disease. But before that, we really need to understand if these machines actually can show us what we want, and how do we use them instead of just trying to see the numbers that is projecting to us. So this is an image I would want to credit Swati Singh from LVP for. This is an interesting collage which shows the meibography of the eyelids in a cadaveric from a cadaveric patient. And then here, as you can see, that there was good histological correlation between the glands. Wherever there's dropout, there is dropout noted even on the histological sections. And as you can see, there is looping of the glands and hooking of the glands here, which can be seen on the histological sections. Also, the swollen glands represent swollen glands and the SNI on the histology. So this just helps us to understand that what we are imaging is pretty much correlating to the histological damage that is seen. And also there is some degree of clinical correlation. So this is just a patient with evaporative dry eye disease who works for 8 to 10 hours over the computer, and he has a lot of discomfort in working. And as you can see, there are multiple clogged meibomian orifices. You know, this is an evaporative type of dry eye disease. There is ocular surface staining associated. He had a normal Sherman's. But what we can objectively do is in real time capture the amount of damage that exists and probably follow up in the future to know if this is worsening, getting better. And the most important use that I see with these machines is being able to tell the patient that, look, this is the issue that you have. We be able to win their confidence, tell them where the issue lies, and then tell them that this is going to be kind of a chronic course, may not be tackled immediately, but we will have to take a certain path. And then it at least helps us prognosticate things better, and also discuss these things with a pictorial representation. Now that we know that there is some amount of anatomical correlation between, this is primarily with meibography that I've spoken so far. So we know how is it correlating with functional effect that the NGD is having. So here you can see this is a serial image or this is a collage of image of the meibography. The top, the panel to the left shows the LipiView scans, which is the meibographic images. The normal shows, and we have the lipid layer thickness towards the right. So in normal glance, we see that here the lipid layer thickness is pretty much close to 100, which is hovering around normal. And in the mild, moderate, and severe disease, we can see that it's gradually going down. So there is some functional correlation where the extent of damage on meibography and the lipid layer thickness is correlating. But it's very important for us to know that there is some variability in the results that we can get. So these scans need to be captured with care, so that these are done before any invasive tests are done in the clinic, without instilling any drops just prior to the scans, and also ensuring the opening of the eyelid is adequate. So these measures should be taken, and then I think these machines can actually give us valuable information. Likewise, again, with increasing severity of meibomian gland dysfunction, we can see that the breakup time actually it becomes faster. So it is just another surrogate measure. We'll be able to assess this on the slit lamp, obviously, but there's also a measure that can be documented in more of a number that you can give to the patient in terms of a graph. And also this is in aqueous deficiency, these tests don't, I think Shermer still and is the best test for diagnosing aqueous deficiency dry, but then there's a whole gamut of tests that you can do. You can analyze the tear meniscus height, which generally can be done with oculus, the lipid layer thickness. Here, this is the graphs from IDRA. And then you can do the non-invasive tear breakup time. And then again, the LipiView for the meibography can be used. So these are all the tests that you can generally incorporate into the clinic if you want to do a dry evaluation. But then it's a very expensive affair. So to just, again, take some clinical scenarios where we can actually use these machines is this particular scenario where this patient is primary Sjogren's. Yeah, this is a patient with Sjogren's syndrome, where you can see that we generally miss the meibomian gland dysfunction, and we tend to just keep treating the Sjogren's, which again becomes an important issue. And also in Demodex blepharitis, it kind of gives us a quantitative measure as to the extent of damage that has occurred with the meibomian glands. And also it, I think, is very important in some cases of ocular rosacea, where the ocular signs can be very subtle and the lids essentially don't look very bad. But when you go in and do the meibography, it actually shows significant dropout in the glands. So in a nutshell, no single test is still very diagnostic, and all these are very expensive. But then we need to have a very standardized way to capture these in case we tend to do so. And we need to interpret it always in conjunction with clinical findings. And though they're very useful, I think they should never overpower our clinical judgment. And then we should just be using both clinical and these objective assessments together to finally come to a diagnosis.